Our next group will be presenting on introducing healthcare disparities in gender minorities, study in an occupational therapy-based program.
Okay. Good afternoon, everyone. The title of our master's project is Exploring Healthcare Disparities in LGBTQIA+ populations in an occupational therapy program. My name is Gritz, and my pronouns are she, her, and hers.
My name is Peihwa, and my pronouns are she, her, and hers.
And my name is Rosmery Nunez, and my pronouns are she, her, and hers.
And my name is Tiara Varela, and my pronouns are she, her, and hers.
And our faculty advisor is Dr. Tribble. Okay. I first want to define what the letters of LGBTQIA+ mean, along with some examples of common pronouns that are seen on the right side of the screen. L stands for lesbian, G stands for gay, B stands for bisexual, T stands for transgender, Q stands for queer or questioning, I stands for intersex, A stands for asexual or ally, and the plus stands for all other non-cisgender and non-straight identities. Let's begin with a bit of background information about the LGBTQIA+ population. In 2022, the statistics of the population in America goes as follows. 57% identifies bisexual, 21% identifies gay, 14% identifies lesbian, 10% identifies transgender, and 4% identify as others. The LGBTQI+ community faces barriers in healthcare caused by stigmas and discrimination that result in mental and physical disparities. This results in poor healthcare services leading to social isolation and mental health difficulties such as anxiety, depression, and mood disorders. Causes of these stigmas are due to lack of proper education, comfort level, and personal exposure in healthcare workers when treating gender minorities. Despite other healthcare disciplines taking strides to eliminate or reduce these LGBTQIA+ healthcare disparities, OT has shown little research in explaining an adequate educational structure that incorporates LGBTQIA+ topics across educational programs. The first task we completed was a systematic review of literature, which came back with 4 major themes, with sub-themes included under each. The first theme discussed was barriers in training instructors on LGBTQI+ content, with the sub-themes of lack of instructor knowledge on LGBTQI's health concerns and time constraints. The research literature explained how there was not enough time to teach the new information along with the designed course curriculum. The second theme discussed was LGBTQIA+ health education content in health profession programs with the sub-themes of terminology and cultural competency. Regarding terminology, research explained the importance for medical students to understand relevant terminologies to avoid any miscommunication or use of inappropriate language. The third theme discussed was methods of integrating LGBTQIA+ content in health courses for instructors with the sub-themes of case studies, group discussions, lectures, and video clips. Research literature explains that lectures, including case studies, discussions, and video clips, were common effective teaching strategies used when implementing material about LGBTQI+ healthcare disparities. The final theme discussed was an increased need for LGBTQI+ education and occupational therapy programs with OT involvement as the only sub-theme. Now, Tiara will discuss the purpose of our study.
Okay, so the purpose of our study was to conduct a pilot test assessing the effectiveness of integrating LGBTQIA+ content into occupational therapy curricula to promote inclusion through diverse teaching methods, aiming to enhance educator competency via a collaborative approach. Okay, so the goal of the project is to reduce healthcare disparities and stigmas for the LGBTQIA population by implementing LGBTQIA health content into an OT graduate program through various teaching methods, and to equip a New York licensed OT instructor to teach within a course to prepare culturally competent future OT practitioners. So we developed 2 research questions to investigate what the barriers were to implementing this content and which teaching methods approaches were most effective and most commonly used, since there weren't enough structured forms of teaching this material in the literature review research. So to begin our study, an inclusion and exclusion criteria was formulated for selection of the participant. The inclusion criteria consists of different requirements needed for eligibility, such as the professional requirements, including occupational type. So our participant had to be an OT professor, and they also had to have a New York registered and licensed occupational therapy professional background. And then they also had to have clinical and educational experience of at least 3 years. And we consider demographics, language type, so English preference, speaking professor, technological accessibility, capability for content integration, and teaching approach requirements. And then the exclusion criteria just states the opposite of the inclusion criteria, which emphasizes restrictions to participation and eligibility. And I would just like to emphasize, just like the last bullet, so a professor who exhibits any bias, discriminatory, and racial beliefs towards the LGBTQIA+ population or teaching about the population is excluded, because of course, we want to reduce the amount of healthcare disparities that are ongoing in this time. And so within our methodology, we conducted a qualitative research design exploring a single case study, and our participant was one New York licensed and registered occupational therapist with 25 years of experience working in psychiatry and 17 years as a clinical associate professor, so he was more than qualified to be within our study. The first meeting was 2 interviews with open-ended questions, and 2 collaborative meetings were held on Zoom, with the interviews being manually transcribed through Google Docs. The first meeting was a preliminary interview comprised of 9 questions that gathered information regarding the participants' teaching and clinical competencies, experiences with LGBTQIA+ content and patients, and potential challenges related to project participation. After a course overview of the participants' weekly lecture topics, a second meeting was convened to deliver an informative PowerPoint presentations with LGBTQIA content from evidence-based research with inclusion of current statistics, data on LGBTQIA+ terminology, pronouns, and mental health topics such as depression, anxiety, and mood disorders, specifically bipolar disorder, stemming from health disparities and stigmas faced by the LGBTQIA+ population. A follow-up third meeting provided inclusion of adjustments made into the participants' original weekly lectures, integrating the relevant and correlating LGBTQIA+ topics and teaching methods proposed during the second meeting. This aimed to align and merge with the participants' lecture structure and teaching style. A semi-structured interview was then conducted during the fourth meeting to evaluate the impact on knowledge and comfort resulting from the provision of the LGBTQIA content, and to facilitate dialogue regarding whether the collaborative process adequately equipped the participant with the necessary tools to teach future OT cohorts effectively.
These are the preliminary interview questions designed to evaluate the participant's knowledge, confidence, and comfort in their role as an OT practitioner, particularly regarding interactions with LGBTQIA+ clients' patients. It also explores whether they have integrated or taught LGBTQIA+ content previously as an educator, and addresses potential challenges and solutions related to participation in the study. The semi-structured interview evaluated the effects of collaboration on participants, assessing changes and increases in confidence, knowledge, and comfort levels. During the final interview, we emphasized our goal, which involved questions to promote discussion on whether the teaching methods in LGBTQIA+ health content sufficiently educated the participant about the population, enabling them to feel prepared and equipped to teach it in future occupational therapy courses for upcoming cohorts. The transcription was analyzed where frequency themes were formulated. 5 themes were found with 9 sub-themes as displayed in the chart. Results in this project were transcriptions from semi-structured interviews. The results were then analyzed into themes. The results shown in the themes are knowledge with subthemes of terminology, statistics, prior knowledge, and pronouns, themes of methods in teaching with subthemes of case studies, PowerPoints, video clips, and presentation, theme of confidence, theme of challenges with subthemes of time constraint and difficulties in adjustment of quality of information, and then finally the theme of organization of content. The results of this project show the participant had prior LGBTQIA+ knowledge and teaching experience, boosting confidence. However, time constraints prevented integration of LGBTQIA+ content into the participant's current course due to the quantity of content he is required to teach. The changes pre versus post collaboration demonstrated significant importance in developing the best strategies for incorporating LGBTQIA+ content into their course. Overall relevance, OT has begun to show research on developing educational structure within the field in efforts to reduce healthcare disparities in the LGBTQIA+ population.
Now I'll be discussing the limitations. So the first limitation is sample bias. The recruitment was done through convenience sampling. So this is a technique where selection takes place due to easy access and availability of the participant. And in this instance, selection wasn't based on the participant being the most representative of the entire population, which can influence the validity and reliability of the results. The second limitation is sample size. As we mentioned, we collaborated with one participant, so the sample size affects the validity and reliability of the results as well. The third limitation is time constraints. As the group members, excluding the participant, there was a process of adding the information to the existing slides of the course and collaborating. So this takes time, and we had to schedule all the meetings where all were in attendance. Also, the participant is currently a clinical associate professor at 4 different institutions, and also a senior occupational therapist in a psychiatric unit in a hospital in New York. So we had to take that into consideration as well. The fourth limitation was methodology errors. As we mentioned, the data was collected manually, so by doing this, you have to consider the possibility of human error when transcribing. We also have to consider the effects of formatting of the questions. They were long questions, and when we were conducting the interview, we realized that there were similarities with the questions, so there is a possibility the participant may have felt that the questions were repetitive. Also, the questions were asked verbally. It might have been useful to condense the questions and have it in writing because there were times that we had to repeat the question to them. The main findings of the collaboration are that we concluded that the participant hasn't implemented LGBTQIA content due to current quantity of information in the course and time constraints of teaching the course content. And the best methods of teaching were determined as case studies, PowerPoint presentations, and video clips. The suggested content consisted of terminology, pronouns, current statistics, and also how OTs can address their involvement within the LGBTQIA population. Lastly, the collaboration was successful in improving the participants' knowledge by helping them find where and how to implement this content and potentially use this for future cohorts. A direction for future studies are implementing LGBTQIA plus health education into other OT courses using various teaching methods, such as the ones emphasized during this collaboration, and strategies to increase exposure. Replicating the project by facilitating a longitudinal study to increase opportunities on how to incorporate the content throughout other OT courses, and increasing cultural and clinical competency. And lastly, possibly developing an evaluation assessment for data collection using quantitative surveys. As we mentioned, this project had qualitative data collection, and these surveys will measure the OT students' competency, effectiveness of implementation, and in return, this information will expand OT literature. And these are our references. We want to thank Dr. Tribble and also Dr. Bruntain for supporting and guiding us during this entire process, and we also want to thank our audience, you guys, for listening. Do you have any questions?
question.
From the nature of the topic, like how might, oh, my microphone. Is that better? Yeah, everyone can hear me? From the nature of the topic, how might you minimize, or how have you considered how you might minimize like the trauma to maybe the researchers as it can, you might get, like you had that criteria of eliminating people who are racist. But if you got that comment, how might you keep yourself emotionally safe?
I'm sorry, I couldn't really hear.
Damn it, I have the microphone.
Just the noise out there.
I'll try
with the beginning
without.
of what you asked.
That's better? All right. How would you minimize trauma or maintain your own safety? Because you had that exclusion criteria of people who are biased or sexist or racist and all that. If you did come across that content while researching, how did you protect yourselves?
So I believe that the whole part of the exclusion criteria was in particular to selecting our participant. So if during the preliminary interview that we conducted with the participant showed any evidence or signs of any racist comments or any negative comments towards the population or beliefs, or maybe the implicit biases and explicit biases were being shown, then that would have actually shifted our whole study and the selection of our participant. So I think we would have just rerouted and turned to looking for another participant at the time.
Okay.
So in that way, we would have protected ourselves as a group and protected the information of the study as well.
Yeah. Sometimes if you come across too many, it's death by 1,000 paper cuts.
That is true. That is true, yeah. So, I mean, that's just all, communication, taking into consideration who we are selecting as well. As we said, it was a convenience sampling. So, yeah, we did have a little benefit just to the convenience sampling method that we used.